Yes, Ms. Maharaj.
Hello. Can I begin? Yes. Okay, so good afternoon, everyone. My name is Roanna Maharaj, and I'm the Vice Chair of the United Kingdom Thalassemia Society. Before I get into what I'm going to address you today and our closing statement, I'm going to tell you just a little bit and remind you about the UKTS. So we are the only UK-wide charity for supporting people with thalassemia, and officially registered in 1978, but active for much, much longer. The society is very small, created by parents to support one another because their children were dying quite young in life. And now we've grown to still small, but we've grown to establishment that advocates for better treatment, patient rights, structured treatment regimes, and to try to help increase quality of life, but also life expectancy of our members. Thalassemia is an inherited blood condition that lowers, alters, or stops the production of hemoglobin. There are several types of thalassemia depending on the severity of the condition. The most severe form is thalassemia major or transfusion-dependent thalassemia. In transfusion-dependent thalassemia, individuals are unable to produce normal adult hemoglobin required to live. As a result of this, individuals living with the condition can become profoundly anemic and require regular blood transfusions ranging from every 2 weeks to 4 weeks from infancy to survive. There is no comparable treatment apart from a curable option, which is bone marrow transplantation, that's not available to over 90% of our patients. Individuals with the condition also receive extensive iron chelation medication. I can tell you, being a patient myself, how difficult it is to undergo this treatment. And without it, you develop organ failures and you prematurely die if you don't treat it well. Infection is also something that contributes to the shortened life expectancy and premature death. And if that wasn't enough, talking about what we're here to talk about, patients who receive contaminated blood products also have to contest with the increased risk of needing hepatic liver transplantation, or they develop liver cancers. Throughout the hearing, we were aware of the small numbers of our community testifying. And despite the best efforts of our team, who also reached out to health professionals who our patients trusted, we also touched base with other organizations who were representing their patients to try to gain some of their insight of how they were able to talk to their patients. We really did find it, we struggled to be able to encourage our members to do so. And one of the things that people spoke about was to relive the trauma of their diagnosis and, the rigorous and horrific treatment with interferon and repeated cycles over and over. It was just too much for them to bear. And with that being said, in most of our communities in which thalassemia is prevalent, there's still an enormous amount of social stigma associated with living with a blood condition. And within sub-communities, the idea of someone living with thalassemia were inaccurately categorized as someone as being a burden or less than, and this one gets me the most, they're not marriage material. So many of our families felt the only way to protect their loved ones was by not disclosing thalassemia, so that they were not stigmatized further. Now, the feelings attributed to the psychosocial burden of thalassemia were then further reinforced by the stigma associated with acquiring hepatitis C. And despite affected individuals acquiring this through their life-saving blood transfusions, that they didn't have any choice, they were worried about the negative attitudes that the general population would have, and the idea of when you think about hepatitis C or B and how it's acquired, they didn't want to be stigmatized further. And I say this because even disclosing it to us, they felt like they'd be judged and that there were whatever negative connotations that would apply to that. And they were afraid that, and I say us as a society, we're quite a new team, but in case somebody spoke about it, and we do have this in our thalassemia community with even people in the NHS disclosing people's sexuality to the community members, there's a real fright. Now, the combined range of factors, including illness-related uncertainty, due to the hepatitis C diagnosis, prognostic unpredictability, the feeling of shame, stigma, and discrimination, as well as the previously unknown fear of transmission to loved ones, all cause that kind of extra additional stigmatization and add it to the burden of their entire health situation. And another factor that we heard about quite often from some of our patients who did want to testify is that they felt by doing so they were letting down the healthcare professionals who treated them and took care of them for their lifespan. And they were enormously grateful to their health professionals because without them, they saw that they wouldn't have lived. And, in thalassemia, and I know in other conditions, we have some amazing healthcare professionals who they do everything in their power to ensure that we have a better chance at life and to live. But I think that was one of the biggest things for them, that they felt that they were being disloyal and that perhaps that they'd be judged or perhaps that they'd be treated differently as a result of this. But going through this, and we listened to some of the hearings throughout, and trying to decipher about what people were, like some of the institutions were saying, in our opinion, we thought what happened in the tragedy was inexcusable, it was reckless, it was heartbreaking, and one of the real tragedies of our lifetime. And as a community, we found it extremely difficult to listen to some of the testimonies and explanations given by several individuals, medical professionals, government, and the health agencies. And a lot of the time, some of these individuals stated that, this event was an unfortunate tragedy and they were sorry. And I don't think it really offers any respite to our community. For one, it doesn't ease the torturous battles that our members faced or that they currently face, nor does it bring back the loved ones that were stolen from our community. And, being a patient, despite your level of education, despite your experience, when you become unwell or you're sick, you have this sense of vulnerability, and I think your family members also have that. And during that time, you look at the ones who are more experienced, you look at your caregivers, you look at the government, the health departments, and you think that they're going to support you, they're going to protect you and provide the best safe treatment. And in this case, that didn't happen. And I think in trying to cope with the realities in front of you, you tell yourself and you reassure yourself that these agencies that are required to observe and regulate, foresee, plan, and evaluate their services along are doing what they're paid to do or doing what they're promised or supposed to do. But in this case, they didn't. They dropped the ball. And due to their reckless behavior, now our communities are left to pay. And, we still speak to parents of, who lost their children. And you see that tragedy, you see their children's experiences through their eyes, and they're still not the same. They still can't talk about it. They still segregate themselves from the community. They still stay away. And I think that trauma of not just what the parents have faced, but the people that are still living with this, saying sorry and that this is unfortunate, will never help them. We have submitted a list of recommendations as part of our written statement, but I'm going to kind of recount some of them. I'm not going to say all. one of our recommendations is I still think that not just our patients, but the community should have access to the medical records. In lots of instances with thalassemia, because liver iron overload gets, you can end up with liver fibrosis and cirrhosis and need for a transplantation. It's very easy for hepatitis C diagnosis to be pushed under the table and focus on iron overload. And that is what I think really happened in our community in some way. When people, perhaps they died, what was probably, so we did do some investigations in it, and what was recorded in some of that is that they died as a result of thalassemia. They died as a result of iron overload. But we don't really know the truth of whether they died because having this infection exacerbated their outcome. So I think there's still a bit in the story that we feel we don't know, and we did try our best to access these documents, and even went to the national statistics, and it was sort of spinning a top in mud. We didn't get anywhere. There's lots of innovative therapies, and because people have been affected by and have been infected with hepatitis, they're not eligible for certain trials because of their previous sort of conditions acquired. Now, I don't think that's fair, because this is not something that they did to themselves. This is not a lifestyle choice. This is what was given to them as an unfortunate gift. So I do think they need, the equality side of what our patients are being offered should be considered. Access to, guaranteed and timely access to liver specialists, pain specialists, rheumatologists, dietitians, nutritionists, physical therapies. These are all issues that are affecting our community, but due to the services, they're not able to seek these treatment options in a timely manner or at all. Most of them can't pay for it privately, and they rely on the NHS. We also thought that we wanted a guarantee that all healthcare professionals, including medical doctors, nursing teams, etc., receive mandatory training and suitably incorporated into medical, nursing, and other allied healthcare curriculums. On thalassemia, the findings of the inquiry, the risks associated with blood transfusions, the importance of consent, ethical training, communication skills, patient-informed decision-making, and patient choice. For us, that's extremely important. We'd also ask for public funding for the UKTS and other organizations to help support our patients. This is something that they have to live with, and we have to ensure that it never happens to anybody else again. A fair compensation package. I don't think it will, I don't know what will ever be fair, but at least these individuals living comfortably, being able to access services, is the least that can be given to them. And also, I think that a recommendation should be given to the NHS Blood and Transplant. I think more people, and donors, for example, I feel sometimes they don't understand the risks that they bring to the recipient. It's great to donate blood. I'm alive because of the blood I've received throughout my life. But I think when people donate blood, they don't understand really that while you're giving this great gift, we can't deal with any more health conditions because it's really difficult to deal with the one that we were born with. So I think there needs to be more emphasis on the communication to the general public, to donors, about how important it is to protect the recipients and to take that responsibility in filling out and answering correctly, honestly on the questionnaires, disclosing information. I do think there needs to be more emphasis on that, and I don't think that the communications that I've been seeing is sufficient. And it is a worry to me every time I have a transfusion, am I going to be protected? In conclusion, in the course of the hearings, it has become apparent that many mistakes were made, and many witnesses have acknowledged that they or the organizations they represented failed in one way or the other. As an organization, as our organization, I think for us, what was reinforced is that our voice, support, advocacy, and our need to call out the injustice in whatever situation we're faced is even more important. And I think there's a lot, being a patient organization, you're always wondering whether you're going to step on somebody's toes, whether you're going to be reprimanded for saying things. And I think there's a real fright for us to be able to come out sometimes and say, I think this is wrong. Or can we ask for a second opinion? And I think this inquiry has encouraged us to begin doing that to a more significant degree. And at this point, UKTS would like to express our profound gratitude to the chair and to everyone involved in the inquiry who tirelessly supported the hearings, our members, and to ensure that they were conducted as effectively as possible. And I think this is the biggest thing that we feel, is that we would like to pay our own respects to the survivors and to the bereaved. We have been inspired, we have been impressed with the dignity of our members who did come forward. And despite the distressing nature, they try their best to continue living and to support the society, to help encourage our members. And it's admirable what they did in the face of this tragedy. And that's it for me. Thank you.
Well, thank you very much. As you know, I've been keen from the start of the inquiry that as many people who had thalassemia, who were prepared to talk about it, should come forward. It's been a worry to me, as I think, again, you know, that we haven't had more, because it seems obvious that there are many who have had a lot of transfusions who would almost, well, not inevitably, because that's the wrong word, but who would probably have suffered, and who aren't prepared to talk about it for the reasons which you've so eloquently just explained. It is a pity that we haven't heard from them, but they have not been forgotten. And I want you to take that back to your members. You've made a powerful case, I think, given that they find it difficult for social reasons, for reasons of experience, for reasons that they feel they may be letting their traditions down, and so on. A powerful case for there being a form of advocacy for them, which they can access. And I want to think more about that. It may be that the NHSBT, whose representative sits at the back of the room as I say this, will give some consideration, possibly, to what can be done for those with thalassemia in terms of giving them a voice beyond that which they already have. And because I want to consider that further. But thank you.
Thank you.
So might I just echo those thanks, because within the inquiry we have been very conscious that there is likely to have been very many people with thalassemia infected because of the frequent nature of the transfusions they have received, than we have had individual witness statements. And Ms. Maharaj's statement helps us understand why it is, for very understandable reasons, we have not been able to hear from more affected individuals. So it's very valuable from the inquiry's perspective.
It may also follow that some of them have not accessed such schemes as are available to get what limited support there is, and anything that may follow later from that. And anything that can be said to encourage them to do that, if they if they want to, it's a matter for them entirely, and their rights to not to do it have to be respected. But they shouldn't miss the opportunity from not being aware of it.
Yes. That concludes the submissions for this week, and perhaps timely in light of the submissions that you've just heard. Our next set of submissions will be by Mr. Corey Wright on Tuesday on behalf of NHS Blood and Transplant.
So next Tuesday, 10 o'clock.